Hello, my name is Teri Meadows. I'm going to be speaking today about cervical and uterine cancer, particularly in regards to health promotion and prevention. Cervical cancer and uterine cancer are quite different, so we're going to start this discussion off by focusing on cervical cancer. Cervical cancer is also known as cervical intraepithelial neoplasia, CIN. It has different levels and gradings, which we'll just briefly discuss here in a moment, but you just need to know kind of your anatomy of the female reproductive tract to understand which type of cancer we're talking about. So most of us already know this, and it is a bit of a review, but just keeping in mind the anatomy, the cervix is the posterior end of the uterus, and cancer is an abnormal increase in cell growth. So therefore, we have an abnormal increase of cell growth in the cervix, and the cervix is the lower part of the uterus. And the cervix is also the most likely area of the uterus to develop neoplasms. There is a grading system for cervical cancer, as you can see here. Level 1 is mild dysplasia, 1/3 of the cervical epithelium, and then as you get to number 2 and number 3, the dysplasia gets more severe to where you're having full thickness of the epithelium in the cervix. This is just important to keep in mind because, like most cancers, the earlier you can catch the disease, the easier it is to treat, and the less likely it is to develop into a terminal cancer. The World Health Organization has identified cervical cancer as the 4th most frequent cancer in women worldwide. However, it is the 2nd most common cancer of women in less developed regions. They attribute this to poor screening in the underdeveloped countries. The screening techniques for cervical cancer, which we will get into further here in a minute, are mostly related to HPV identification and prevention, and these efforts are not as readily available in the less developed countries, nor are screenings with pap smears. So 7.5% of all female cancer deaths were attributed to cervical cancer in 2012, and 85% of these deaths occurred in less developed regions. Now we need to look into what causes cervical cancer. Human papillomavirus contributes to the development of premalignant cervical lesions. There have been other causes identified, but they are less clear, and HPV is the strongest leading cause associated with most cervical cancers, particularly HPV types 18 and 16. They have the strongest link to invasive squamous cell carcinomas. Squamous cell carcinoma is the most common at 80%, and HPV-18 has the poorest prognosis. 15% of HPV-related cervical cancers are adenocarcinomas, and 3 to 5% are mixed adenosquamous cell types. Listed below are the risk factors for cervical cancer. Because cervical cancer is so closely related to HPV infection, and HPV infection is a sexually transmitted infection, a lot of these risk factors are similar for other sexually transmitted disease risk factors. So you can see early intercourse and early marriage, multiple sexual partners greater than 2, early childbearing, prostitution. Those are some of the riskier behaviors. Also, genital infections or infections in a partner can put somebody at a higher risk. Those are mostly lifestyle related and modifiable risk factors. However, some of these are non-modifiable, such as immunosuppression, exposure to radiation, whether that's medical radiation or environmental, that would depend on whether it's modifiable or not. Lower socioeconomic status, exposure to DES intrauterine, which is non-modifiable. Cigarette smoking would be a modifiable risk factor. Some vitamin deficiencies, particularly A, B, C, and folic acid, have been linked to cervical cancer. Hispanic women have the highest incidence of cervical cancer, followed by African American women, and the lowest risk are American Indians and Alaskan Native women. Women in their early 30s with advancing age, the older you get, the more likely you are to develop it. However, it's usually the early 30s and a little bit before then that the woman may have contracted the HPV infection. It's important to know that just because somebody has HPV doesn't mean that they're necessarily going to develop cervical cancer. Most HPV infections will clear on their own, and many precancerous lesions will resolve spontaneously. However, there's always a risk that a precancerous lesion will progress into cancer, and it usually takes 15 to 20 years for the actual cancer to develop. 5 to 10 years for those with a weakened immune system. This is just a little bit more information about HPV. The human papillomavirus. It is the most common viral infection of the reproductive tract in both men and women, and most sexually active men and women will have some variant of HPV in their lifetime, and may often be reinfected. Most types of HPV do not cause problems and will resolve on their own. However, like I said before, there are the few types that are linked to cervical cancer. And nearly all cases of cervical cancer can be related to HPV. HPV can also cause cancers of the anus, vulva, vagina, and penis. HPV can also cause genital warts and respiratory papillomatosis. These are much more rare, and the respiratory papillomatosis is very rare, and that is where tumors grow in the air passages leading from the nose and mouth and into the lungs. However, genital warts is very common and is very infectious. Patients may present with some different subjective symptoms that are related to cervical cancer or pre-malignant cervical lesions. So on the left there, you'll see the pre-malignant lesions. It's mostly history related. So if they have a history of risk factors that we've discussed before, if they've had repeated vaginal infections with symptoms, if they have a history of poor gynecologic care, or particularly if they haven't been receiving the recommended pap smears, usually every 2 to 3 years, if they've been normal is what the recommendation is after the age of 21. So if they haven't been doing any of those things, then you could be suspicious for cervical cancer. Now, once it becomes an invasive carcinoma, that's when you're going to hear more of the kind of objective symptoms. However, they may not present with them at the moment, so it would be subjective if they're not having these symptoms at the moment. So they may say that they had been having some brown titch vaginal discharge. They may have had some irregular vaginal bleeding. A lot of times this will be noticed spontaneously or directly after intercourse. They may have some back, leg, or pelvic pain. Some other symptoms might be just symptoms of cancer in general, like fatigue, weight loss, or loss of appetite. And they may have some vaginal discomfort or odorous discharge. And one of the other interesting ones that patients may say that they've been having a single swollen leg, which always is a cause for concern. So it's important to keep in mind if any woman comes to you with any abnormal vaginal bleeding that is unexplained by hormones or other causes, then they always need to be referred to a gynecologist to make sure that there isn't an underlying pathology or a cervical cancer. But here are also some objective symptoms, and it's good to know that they may not have any symptoms, and that is pretty typical for this. They often will be asymptomatic, and when you do a pelvic exam, you may notice that there might be some lesions on the cervix or in the vaginal vault. Usually it would be actually on the cervix though. The cervix might be friable, so when you touch it, it's kind of like really irritated looking and red, and if you touch it with your Q-tip, it might bleed a little bit. That's what friable is. And then there might be an appearance of condyloma on the cervix, which is kind of that bubbly looking, I mean, we all know what condyloma looks like. It's the raised, hard, dry bumps on the cervix, and they would most likely have an abnormal pap smear. There's lots more to talk about with this as far as protocols and treating the cytology, but that is not the focus of this lecture. If you are interested in learning more about how to diagnose and treat cervical cancer, definitely refer to our book. Dunphy Table 14.1 on page 741 has a great explanation of different things that you would want to look for in the pap smear and what you would need to do with the results that you get. Since we're just talking about prevention and promotion, I don't think I'm going to go into that in detail with you. Just know that the resources are there if you need them. The best screening tool available for identifying and preventing cervical cancer has been the pap smear. The pap smear is where a sample of cells is collected from the cervix and then tested for cytology. And since the introduction of the pap smear, there has been a 70% reduction in cervical cancer. It is able to detect precancerous and early cancerous lesions before the cervical cancer gets out of control, which is fabulous. So we as nurse practitioners need to make sure that we are collecting an appropriate sample with the pap smears. Since the pap smear is the #1 screening tool that we use right now, it's very important that we're doing it properly and that we know how to do it. We need to be competent in this because this one simple procedure can really have great implications in how our patients are treated and if they need further treatments or prevention efforts. So just make sure you kind of review this. You want to make sure you label your specimen and fill out the paperwork correctly. You never want to collect if the patient has a vaginal infection or current abnormal symptoms. You would always want to collect from both the internal and external Oz with the swab. And just know the lab does rate the samples that they're given based on the cells that are obtained, the quantity, and the types. So they rate them as satisfactory, unsatisfactory, within normal limits, or other. And sometimes if it's an unsatisfactory sample or other, there may need to be a repeat sample taken in 8 weeks. And you do have to wait that amount of time, so it delays treatment for patients. And then just know that if you do get the abnormal results, there's guidelines to follow. Again, you can refer to the text Dunphy on pages 741 to 742 to see different things you would do based on the different results that you get from your pap smear. There are a lot of different factors that can affect the pap smear results, so just kind of read through these quickly. I'm not going to read through all of it, but basically just knowing, you want to get a really good history on your patient before you do the pap smear. If they're having any current abnormal symptoms, you would want to wait until those have been treated and resolved. And then you want to make sure that your patient, isn't doing some of these things on their right, like they haven't been douching, they haven't been changing up their birth control methods without letting you know. They didn't just have intercourse right before they came in, things like that, because all of that can change the cytology. So just be mindful of that. So it's good to know that with the pap smear, false positives are less than 1%. So it's very, very rare that a patient gets told that they have cervical cancer when they don't. However, there are a lot of false negatives, and these rates really do range a lot. From what I saw, it was like from 1% to 80%. Can the cytology be a false negative depending on which study you're looking at and who's collecting the sample? But it's almost always these false negatives are due to sampling error. So it's either because the person who collected the sample did it improperly, or maybe the patient had an infection when they did it, or maybe just not enough cells were collected for them to perform an adequate test. So just this takes us back to those few slides before. Know how to collect the sample with the pap smear and make sure you're doing it properly and efficiently. And also know, so the sample error rate is around 60%. That means that the person who obtained the sample is probably, is 60% of the errors are related to that person. However, 40% of the errors are related to screening, meaning the actual laboratory results. So perhaps the cytotechnologist looked at the cells under the microscope and just missed a couple abnormal cells that really were present. So we need to make sure that all of us in the medical profession are doing our jobs, doing it properly, collecting the appropriate sample, and also actually looking at the sample very efficiently and thoroughly. So the guidelines for screening for cervical cancer are developed by the American Cancer Society, but there are a group of institutes and associations that are also supporting these recommendations, like the American Medical Association, the National Cancer Institute, the American Nurses Association, the American College of OBGYNs, and the American Academy of Family Physicians. The main recommendations from all of these groups say that we should start screening through the pap smear at the age of 21, no matter if a person has been sexually active or not. Women from the age of 21 to 29 should have a pap done every 3 years, and if they've had abnormal paps with any of these, it would be more frequent and you would need to refer to the guidelines for that. After the age of 65, and if the person has had 10 years of regular results with no abnormal results, then no further testing is required. If somebody has had a total hysterectomy for reasons other than cancer, then no testing is necessary. However, if they've had a hysterectomy due to a uterine or cervical cancer, then they're probably going to require more frequent screening. And then we also just need to know that all of these groups recommend that the vaccination with HPV should be done for all young adults, and we'll get further into that in further slides here, but whether or not they've had HPV or not, you should still get the HPV vaccination. We can help prevent cervical cancer by offering HPV vaccines to men and women from ages 9 to 26. Central District Health actually recommends that young women get the HPV vaccine until they're 27 years old, and young men to get the HPV vaccine by the age of 22. However, young men who have sex with other men or who have weakened immune systems can also get the vaccine until the age of 27. It is important to remember that although it's recommended for younger to start at age 11, it can still be given up to the age of 22 to 27 in many people as well. We tend to think of vaccines as things just for children, so this is just something to also keep in mind, specifically when talking about young adult populations. Another thing we can do to prevent or catch cervical cancer early is to do pap smears at the recommended intervals starting at age 21. Guidelines say that women should not receive any pap smears prior to the age of 21, and they should receive them every 3 years as long as their pap smears have been normal. If they've been abnormal, or if the patient has any concerns that put them at higher risk for developing HPV or cervical cancer, then you follow the guidelines to determine at which intervals the patient should get their pap smear screenings. Another thing to do is just raise awareness, both among the medical field and among the public, that cervical cancer can be easily prevented, and the best way to do this is by vaccinating teens and young adults. And just keeping in mind that women need to have their yearly annual exams with their providers as well as their pap smears, most typically at 3-year intervals. I started out my research on this thinking that uterine cancer and cervical cancer were one and the same, but I quickly learned that they are quite different. So I kind of wanted to separate this PowerPoint presentation out by starting with cervical cancer, and now we're going to move along into uterine cancer and just kind of discuss a lot of the differences between them and some of the similarities. Uterine cancer is cancer of the uterus. It is often referred to as endometrial cancer, so that kind of got me a little confused when I started out this research because although it can be called endometrial cancer, not all uterine cancers are in the endometrium. The uterine sarcomas, as you'll see the two types there, are in the myometrium, which is the supporting connective tissue of the uterus. But it's much more rare, so almost all causes of uterine cancer are the endometrial carcinomas. So that is why people will use the phrase uterine cancer or endometrial cancer to mean the same. So just know, basically, uterine cancer arises most often from the endometrial lining. However, it can come from any part of this upper body of the uterus. It can also be called the corpus or the body of the uterus rather than the lower part, which would be the cervical cancers. So just a little bit of anatomy there and some understanding of terms that are used to describe uterine cancer. And here again is another slide that just kind of talks about the grading and typing of uterine cancer. Basically, what I gathered from this is type 1 cancers are typically estrogen related and type 2 are not, and then they're also graded based on the amount of cancerous tissue in the forming glands. So grade 1, type 1 would be estrogen related because it's type 1. It is the most common, and the tumors have 95% or more of the cancerous tissue forming glands. So although 95% is a higher number, it's good because it's in glandular tissue. It's not spreading out to other areas. And then grade 2, type 1 or 2 can be either estrogen related or non-estrogen related, and that's where 50 to 95% of this is in the tissue forming glands. And then grade 3, type 2 is the worst. It has the worst prognosis, and it is the most aggressive type of uterine cancer, and that is where less than half of the cancerous tissue is forming glands, and it is aggressive with poorer outcomes than the lower grades. So just know when we're talking about prevention and promotion, a lot of it with uterine cancer relates to hormones and progesterone and estrogen. So this is all talking about basically grade 1, type 1, which is the most common and really the least aggressive. Uterine cancer is the most common gynecological cancer. The average age is 60 years old, and it has an 80 to 85% overall 5-year survival rate. Now, that rate drops to 78% survival rate if the depth of invasion was more than 66% at diagnosis. So this is where we just all need to keep in mind, like most cancers, early detection is the key. Now we'll talk about the cause of uterine cancer. Although this isn't the case for every single type of uterine cancer, this is the case for most of them. So the main reason for most uterine cancers is hyperplasia of glandular tissue, and it is most often an estrogen-progesterone imbalance related issue. So estrogen needs progesterone for a counterbalance. So usually these uterine cancers are because of at some point in one's life, there was a decreased progesterone. The risk factors for uterine cancer are quite different from those of cervical cancer. So you'll see here, African American women do have the greatest risk and the poorest survival rates among those with uterine cancer. You'll also see that quite a few of these are modifiable risk factors or preventable. Now, with the unopposed estrogen, what they've found is women who have used progesterone-containing oral contraceptives for at least 1 year of their life have been shown to have more protection against uterine cancer. So women would have only had to have used a progesterone-containing oral hormone for 1 year, and then they would be protected for 10 years. So even if they stop the hormone after a year, they will still be provided protection, and their risk factor drops in half for having the chances of getting uterine cancer. So progesterone has been shown to provide a protective factor with uterine cancer. A lot of these other things, early menarche is another reason that somebody might be more likely to have uterine cancer, as well as advancing age, just because the older someone gets, the more likely they are to have this. The other thing that was a little interesting was the tamoxifen. So tamoxifen is an anti-estrogen in breast tissue, but it acts as an estrogen in the uterus. So it will thicken the lining of the uterus in women that are postmenopausal. So this mostly just relates to postmenopausal women. Polycystic ovarian syndrome also makes sense as a risk factor. Other things that kind of go along with obesity and just inactivity and unhealthy lifestyle in general, like a high-fat diet, PCOS, obesity, hypertension, diabetes mellitus. A lot of those will also increase your risk for having uterine cancer. Having never had a child will also increase your risk. The use of an IUD, now this just, studies have only been done on the use of an IUD that does not have progesterone, so they're not sure. In fact, it would kind of, to me, make sense that an IUD with progesterone would actually help with preventing uterine cancer. However, this is talking about an IUD without hormones. So that just kind of irritates the uterus and causes more dysplasia in there, which could be a risk factor for uterine cancer. And then any woman who takes estrogen after menopause also will have an increased risk of uterine cancer. I also need to add to this that there are a couple other risk factors, mostly related to history and family history. So other risks of having uterine cancer are if a patient has had breast or ovarian cancer in the past, if they've ever had an endometrial dysplasia in the past, if they have any close relatives with endometrial or colorectal cancer, and if they've ever had radiation to the pelvis or to treat other cancers. The most common symptom of uterine cancer will be postmenopausal abnormal vaginal bleeding. 80% of the times when somebody that is postmenopausal has abnormal bleeding, 80% of the time it will be attributed to uterine cancer. So just keep that in mind. If you have any patient that comes in postmenopausal that has any bleeding, they need to be referred for an endometrial biopsy because this is highly suspicious of uterine cancer. Other things to just be concerned about with uterine cancer is they could have symptoms of perimenopausal irregular bleeding. So if they're having any irregular bleeding, you need to put this into your differential diagnoses. And oftentimes, though, there's not going to be any sort of other symptoms. There might not be any pain, and no abnormal symptoms may be noted until the cancer has metastasized. Unlike cervical cancer, uterine cancer does not have a great screening technique or tool. So there is no standard screening for uterine cancer. The main thing with uterine cancer is prevention with progesterone. However, if a pap smear is done and it shows atypical glandular cells, an endometrial biopsy will be performed to rule out uterine cancer. Just know that that's not anything that's a standard screening. We don't just go around doing pap smears to look for uterine cancer, and we don't go around doing endometrial biopsies unless there's cause for concern. Prevention with progesterone is probably the biggest thing we can do to help prevent uterine cancer. And the main thing we can do is just watch for those symptoms like the irregular vaginal bleeding after menopause. That's the main thing we can do as a provider to hopefully prevent or worsen any uterine cancer. So protecting the uterus, I just remember this, the pro protect the uterus with progesterone. So hormone therapy prior to menopause is one of the best things we can do to protect the uterus. High consideration should be given to provide progesterone therapy to any woman with any irregular ovulation cycles to protect the uterus. The American Cancer Society recommends that an endometrial biopsy at menopause and then occasionally for high-risk patients only. So only if there's a patient that has a lot of the risk factors or may have polycystic ovarian syndrome and, multiple risk factors would they need to just go and just do an endometrial biopsy on. So, like I said, there's not really a great screening tool. It's mostly just being aware of what the symptoms are, and if a patient has these symptoms, do what you can to get in there and rule out the uterine cancer. We also need to just make sure that we're really, really good at teaching every single postmenopausal woman that they need to report any abnormal bleeding, because this is a huge cause for concern. The American Cancer Society recommends that patients prevent cancers and promote health by their campaign called Take Control of Your Health. So underneath this broad umbrella of all cancers, they have formed some recommendations. And this can just be just overall health for all of our patients. So stay away from all forms of tobacco, stay at a healthy weight, stay moving with regular physical activity, eat healthy and include fruits and vegetables into your diet, limit alcohol intake, protect your skin, and know yourself. Know your family history and your personal risk factors. Get regular checkups and cancer screening tests done. A community plan that I think is very important, mostly in relation to cervical cancer, is to really get out there and improve the rates of HPV vaccinations, particularly in Idaho. So HPV vaccines should be given to everyone, particularly those who have been at higher risks and who have lower rates of immunizations. It's been noted that Hispanic women do not get immunized as well and also have higher rates of HPV. So we could focus on them, but I really wanted to focus my community plan on Idaho. So I was looking at some of the statistics in Idaho, and I found that Idaho has been placed at 47th of all the 50 states in the nation for vaccine-preventable disease coverage. Perhaps because of parent refusals, insufficient documentation of immunization records, and the need for more medical personnel education. So we really need to work on getting our immunization rates in general better in Idaho. We are nearly at the very bottom of the list when it comes to our vaccination statistics. So we just need to really get out there and encourage and almost make it a protocol that, unless declined, every patient that comes into the pediatrician or the primary care doctor's office from age 11 to 12, boys or girls, we ask and offer the HPV vaccine. We just basically need to treat it like it's an expected vaccine and just say, okay, you're getting your HPV vaccine, you're this, as well as your other vaccines that are recommended at that age, unless a parent or patient declines. And in that case, and in the case that they do decline, we need to make sure that they've been given the education that is appropriate. So the Idaho Central District Health Department, we just need to let them know, recommends that boys and girls ages 11 to 12 receive 3 doses of the HPV vaccine. And we also need to make parents and patients aware of the fact that the HPV vaccine is most effective when it's given prior to sexual activity in life. However, it can still provide protection even after sexual activity has begun. Another thing that a lot of parents are fearful of is that, well, if I give my kid this HPV vaccine, then they're going to just go ahead and engage in risky sexual behaviors. But there have been some studies done that have not proven that that is the case. And teens do not behave any differently whether or not they have the HPV vaccine. And actually, HPV isn't one of the top STDs on their list of ones that they could get from sex. So they're more concerned about chlamydia, gonorrhea, HIV than they are about HPV. So although it really does cause a lot of problems in the future, if they get HPV, particularly the ones that lead to cervical cancer, they're more concerned about some of the ones that they're going to see immediately, like they're going to get some symptoms from within the next month. So those are the ones that they're more concerned about rather than HPV, which leads to symptoms further on down the road for them. We also just need to make sure that providers are educated to just be expected to give the HPV vaccine in, like we said, the recommended age groups, and that they understand that the HPV vaccine is it is the best thing we can do to prevent cervical cancer. So it's just something that we should be doing because it's just a fabulous vaccine. So one of the things I came across was this local shot line, and this is for Idaho, but you can call 208-321-BABY. And if you ever have any questions as a nurse or a nurse practitioner or a parent or a aunt or an uncle of a teen or a young child that needs immunizations, you can give this phone number a call, and they will answer any questions that you may have about vaccinations for kids. So I thought that was a great local resource. Central District Health Department worked with a large group of medical offices in the Idaho areas and had a grant to focus on immunization education programs in Idaho. Their efforts increased immunization rates within 3 years by 10.5%. They increased healthcare knowledge, and they also increased the use of the IRIS system. So they focused on healthcare professionals. They taught them how to use the IRIS system and how to, and the importance of documenting every vaccine in that system to improve both tracking and, care. If a patient goes from one family practice to another to Central District Health, everybody could see where they're at with their vaccinations. So improving the use of the IRIS system was just one of the main tools they used to help increase the immunization rates, as well as just going out into the community and into these medical offices to really promote immunizations. The challenges that they came upon were that there were problems with standing orders and consistency in immunization scheduling. They also found out that healthcare personnel that were really good at maybe getting this implementation up and going then either moved on to another job or quit, and so they just were having a hard time maintaining these healthcare personnel, and it led to a decline, and when they lost some of these great personnel, there would be a decline in the immunization rates. So what can we do as healthcare professionals, both as nurse practitioners and as nurses out there working in the Idaho community? We can just make sure that we use the protocols for encouraging HPV vaccine and any vaccination. So just make sure that there's a protocol set up at all family practice clinics, as well as pediatrician offices, Central District Health Departments, any of the places like that are seeing this population, the 11 to 12-year-olds particularly, as it relates to the HPV vaccination. So just ensuring that they are using the protocols that the Central District Health Department has recommended and really encouraging patients and family members to offer the vaccine to their children. We want to make sure that everybody's documenting in the IRIS system, as we discussed earlier, and monitoring any missed opportunities. We also want to utilize the IRIS immunization reminder system. They have a little system you can go into, and it's free to any office or provider, where the system just sends out little reminders to the family through email about when their immunizations are due. So I think that's a great tool to utilize. And then always just know that we can use this shot line, 321-BABY, if we have any questions about vaccines. We need to make sure that we're getting everybody involved in the opportunities to provide HPV vaccinations to children and teens. We want to make sure that healthcare providers are consistently recommending the HPV vaccination. We want to make sure that parents are educated on the safety and efficacy of the HPV vaccine. And specifically, if you go to this website, www.immunize.org, there's a list of the HPV vaccines and the take-home paperwork. I'm sure you're all familiar with those little forms that we give with each immunization. But just having those handy in all the offices, in the daycares, the teen clinics, the schools, the sporting events, anything we can get out there into the community that's just information about the HPV vaccine and how effective it is in preventing cervical cancer is going to help. So that's kind of one of the main easy low cost things we can do is just distribute information. And I am going to make sure I do this at my children's daycare, at the clinics I go into with my nurse practitioner education, and the urgent care that I work with, just to make sure that everybody's aware of the HPV vaccine, because I think there's a lot of confusion out there in parents and in teens, because it's not really one of those that's mandated, but it's recommended, and so some people just decide they don't want to get it. But I think if they really knew how important it was and how much it helps prevent cancer in women, I think that more people would be on board to get it, because it really has minimal risks and great benefits. So we just need to make sure that we're all aware of this, and we need to pass the information along, and we need to be prepared to answer any questions that parents may have of us. I want to thank you for your time today, and please, if you have any questions, let me know. This concludes my discussion on cervical and uterine cancer, and I hope you did learn a lot from this. I know I did in the making of the PowerPoint, so if you have anything to add, any personal stories, I'd love to hear them. Thank you.